Hello, welcome to my assignment, which is the Assessment and Psychotherapy Desk Guide. So first we're going to talk about autism spectrum disorder, and this is a persistent deficit in social communication and social interaction across multiple contexts. According to the DSM-5, autism spectrum disorder would be coded as F.84.0. Other things to note about autism spectrum disorder are the deficits in nonverbal communication, deficits in developing, maintaining, or understanding relationships. Repetitive or restrictive behavior can also be present, and certain activities can be noted, such as lining up toys, echolalia, and idiosyncratic phases. So risk factors of autism spectrum disorder include genetic factors, chromosomal conditions, family history, and other precipitating factors such as older age of parents at birth of the child, low birth weight, and it is predominantly in males but also can occur in females. And some screening recommendations and diagnosis include the Developmental Screening American Pediatrics, which recommends developmental surveillance at every well visit, and there is no screening recommendation on children 18 months to 30 months old if there is no concern that was raised by the parent or clinician. Some tools and instruments include the modified checklist for autism in toddlers. The revised MCHAT is a popular 20-question test designed for toddlers between 16 and 30 months old. There is recent evidence that the MCHAT may not be as effective in screening females or minorities, urban and low-income children. There are also other screening tools such as the ASQ, the STAT, and the PEDS. And some of these are general development screening tools, others are interactive screening tools, and the PEDS is a general developmental parent interview designed to identify delays in motor language, self-help, and other deficiencies. So this screen just shows a MCHAT, which it's a questionnaire, and it will show the psychometric properties, and basically the screening will show a low risk, a medium risk, or a high risk, and this can detect many cases of autism spectrum disorder in toddlers, and usually physicians will use a two-stage screen, and that will make them more confident that there is a positive case. So a low risk would be between 0 and 2 if the child is younger than 24 months, and then they'll be screened again after their second birthday. There's no other action required unless surveillance indicates a risk for autism spectrum disorder. So trauma is coded as PTSD and the DSM as F43.10, and post-traumatic stress disorder in the DSM-5 is listed under trauma and stressor-related disorders. And PTSD is exposure to a traumatic event and the subsequent development of symptoms that fall into 4 clusters, including intrusion, avoidance, negative alterations in cognition and mood, and alterations in arousal and reactivity. There are many screenings for PTSD. The gold standard is the CAPS-5, which is the clinician-administered PTSD scale for DSM-5. And this is an interview-based assessment tool. There are also other screenings involved, including a PTSD checklist, which is a 20-item self-report tool. There's also something known as the trauma screening questionnaire, which is also used in PTSD screening, and that is known as the TSQ. And there are multiple other alternatives for screenings as well, but again, the gold standard is the CAPS-5. So this is a structured diagnostic review interview for post-traumatic stress disorder. The total score will range from 0 to 80, and the score is calculated by adding up all the portions together. And each symptom is scored on a severity rating from 0 to 4, 4 being most extreme. And basically, if the intensity and frequency classifications are the same, then the severity rating will be the same. If either intensity or frequency is lower, the lower rating is the severity rating. So the psychometrics are very strong, where there's interrated reliability and test-retest reliability, and there's a strong correspondence with diagnosis based on the CAPS for the DSM-5 total severity score. It's psychometrically sound, and according to the DSM-5, the PTSD diagnosis with the symptom severity is noted using the CAPS-5. This slide shows the PTSD CAPS-5 screening tool, and there's things here noted such as intrusion, avoidance, cognition and mood alteration, and arousal and reactivity alteration, which would be shown by using the screening tool. And the diagnosis is made for people over the age of 6. There has to be at least one intrusion symptom present, at least one avoidance symptom, and at least 2 cognition mood symptoms present, and as well as 2 arousal reactivity symptoms to be diagnosed with PTSD based on this screening. Some things noted are recurrent distressing memories, flashbacks, etc. So right here we'll see a PTSD-5 screening tool. This is from the National Centers for PTSD. The score can range from 0 to 5 being the highest. And basically, if there's a trauma history, they are instructed to answer 5 additional yes or no questions about how the trauma has affected them. And the total score is from 0 to 5. Counting yes is going to be considered 5, which will be a high PTSD scoring rating based on this screening tool. Right here we have the PCL-5, and this screening tool proposes to determine how bothered a patient has been by each 20 items, and this would be within the past month. This is based on a 5-point Likert scale. The sum score is between 0 and 80, and typically scores of 33 or higher indicate possible PTSD, so the higher the rating, the higher the chances that there is a positive diagnosis for PTSD. And if someone is rated on moderately or high, that would be a 3 or 4. Those would be particular areas of concern to be monitoring. So next we have generalized anxiety disorder. In the DSM-5, it's noted as an ICD code of F41.1. This is defined as excessive anxiety and worry, which is an apprehensive expectation occurring more days than not for at least 6 months about a number of events or activities. There is an association with 3 or more of 6 symptoms, and these include restlessness, easily fatigability, difficulty concentrating, irritability, muscle tension, and sleep disturbances. For screening tools, we have recommended by the USPSTF screening for anxiety disorder in adults, including pregnant and postpartum persons. A popular screening tool is the Generalized Anxiety Disorder 7-item scale, the GAD-7. This is a self-administered questionnaire that screens for GAD and assesses its severity. The GAD is available in multiple languages, so it's effective. It's a very effective tool to determine if someone has generalized anxiety disorder. There's also what is called the Penn State Worry Questionnaire, the PSWQ. This is a 16-item self-report questionnaire, measures the frequency and intensity of chronic and uncontrollable worry. Also very commonly used is the Beck Anxiety Inventory, and this is a scale that measures the severity of anxiety. Also, we have the Hamilton Anxiety Rating Scale and the Overall Anxiety Severity Impairment Scale, also known as OASIS, and that is a quick evaluation of anxiety's total severity and impairment to the patient or client. Right here we have the GAD-7, and it's a 7-item instrument used to measure and assess GAD severity. In the past 2 weeks, we have them answer questions that how bothersome these types of symptoms have been based on not at all being 0 and scoring all the way up to 3, which would be several days, more than half the days, and nearly every day. And the scoring would be totaled at the bottom to indicate severity of the anxiety. So next we have the DSM diagnosis of major depressive disorder. This is an ICD code of F34.81, and a major depressive disorder is characterized by 2 primary diagnostic criteria. There is going to be depressed mood and loss of interest. which is also known as anhedonia. At least one is present for at least 2 weeks. So right here we have the definition from the DSM-5 based on major depressive disorder, what an episode looks like, what it entails, what are the symptoms that are causing clinical significantly distress, impairment in social, occupational, or other important areas of functioning. And the occurrence of the MDD episode is not better explained by a schizoaffective disorder, or schizophrenia, or some other neurocognitive disorder, or some kind of psychotic disorder as well. So screening tools include for screening for depression in the adult population, the USPSTF recommends screening. Also, the tools that are most commonly used is the PHQ-9, the Patient Health Questionnaire. Scoring each item will give indications of a major depressive disorder in a client. There's also the Zung Self-Rating Depression Scale, and other scales that are sometimes used are the Hamilton Rating Scale for Depression, the HAM-D, or the Center for Epidemiologic Studies Depression Scale, the CESD. The Hamilton Rating Scale for Depression is noted here, and we're going to go into, there are several versions, including a 6, 7, 8, 17, and 21 item Hamilton Rating Scale for Depression. This one noted here is going to quantify the severity of depressive symptoms in patients who already have a depressive disorder diagnosis. The original 17 items, 0 to 2 or 0 to 4 scale according severity. Total score is going to be applicable to whether or not the patient scores on having a major depressive disorder. 0 to 7 is within normal limits, all the way up to 25 and above, which would show severe depression. The PHQ-9 Depression Questionnaire is also another very commonly used scale for monitoring depression. A score ranging from 0 to 27, 10 or above is suggestive of the presence of depression. According to the DSM-5, major depressive disorder is likely if 5 or more of the 9 criteria symptoms are present for most of the day, nearly every day, over the past 2 weeks. However, some of the symptoms must be either depressed mood or anhedonia. And this is reflected in questions 1 and 2 on the PHQ-9. Any degree of SI would count towards a provisional diagnosis, and the symptoms must also cause significant distress and loss of function. Again, the PHQ-9, it's limited to making provisional diagnosis. It's not to make an actual diagnosis. Substance use code based on substance class is characterized by taking substances in a larger amount, and goes on, this slide will go on to tell you some other really detailed instances of what classifies as a substance use code based on substance class. So there's other things involved, such as continuing to use if it's causing problems in relationships, using them repeatedly when it's even putting you in danger, etc., etc. And the last one would be development of withdrawal symptoms, which can be relieved by taking more of the substance. So a lot of these indicators would be indicative of a substance use code. And again, it would be based on the substance class. So the screening tools involved are a recommendation of screening by asking questions about unhealthy drug use in adults aged 18 years or older. Screening should be implemented when services for accurate diagnosis, effective treatment, and appropriate care can be offered or referred. And the screening involves asking questions about unhealthy drug use. Examples of these screening tools are the Screening to Brief Intervention, the S2BI, the Brief Screener for Alcohol, Tobacco, and Other Substances, the TAPS, and the Opioid Risk Tool, the OUD, or the ORT-OUD. This tool here is a screening tool for OUD, Opioid Risk Tool. It's commonly used to measure risk for aberrant drug-related behaviors in patients with chronic pain prescribed opioid therapy. This tool can be used upon an initial visit prior to beginning opioid therapy for pain management to indicate whether the person is at risk for an opioid use disorder, pending they be prescribed pain medication for chronic pain. Scoring of 3 or lower indicates low risk, 4 to 7 indicates moderate, and 8 or higher would indicate a high risk for opioid abuse in this client. The craft screening interview is another tool that is used to validate. It's a validated assessment that identifies substance use, substance-related driving risk, and substance use disorder among adolescents aged 12 to 21. So you can see here the craft screening interview. It asks questions and it follows down and it gives you a total sum score. Pediatric anxiety and depression, this falls under anxiety disorders F93.0. This includes separation anxiety disorder, selective mutism, social anxiety, and then there's also depressive disorders and disruptive mood dysregulation disorder, MDD, major depressive disorder, and persistent depressive disorder. Screening for child anxiety-related emotional disorders, the SCARED, is used for in patients 8 years and older. The Spence Children's Anxiety Scale is a psychological assessment tool designed to evaluate anxiety symptoms in children and adolescents. And there's also a revised CADS. It's a 47-item youth self-reporting questionnaire. And the subscales include separation anxiety, phobias, GAD, panic disorder, OCD, and MDD. So here you can see an SCAC, Spence Children's Anxiety Scale. It's comprehensive, it's child-specific, it is reliable and valid. There are 44 items. It's a 4-point scale, and it includes indicators of frequency and symptomology. This is a self-report measure, and it is complemented by a parent's version, which would assess the parent's perception of their child's anxiety. And there have been validation studies to that this scale possesses good psychometric properties. It's highly internally consistent. There's good retest reliability, and valid discrimination between children with and without anxiety disorders. Okay, and then we go into the major depressive disorder Beck's depression inventory scale. Here, it's a 21-item self-reporting rating. Again, the higher the number, the more apt there would be to have a major depressive disorder. And this here is the generalized anxiety disorder tools used. There's the BAI, the Beck Anxiety Index. We also have the scoring below here. All questions is not at all would be a 0. Severely would be a 3, and we would just go down the line and sum those up. And this scale is basically a scale to self-report measures of anxiety. For suicide, which would be known as potentially self-injurious behavior with at least some intent to die, according to the APA, age recommendations for screenings include youth ages 12 and older as a universal screening recommendation, youth 8 to 11 screening when clinically indicated, and youths under the age of 8 should not be screened. It's not indicated, but there should be assessment for suicidal thoughts, behaviors if there are warning signs present. Here we see that we have the suicide risk screening tool, and it would ask the client some questions here, and some tools also known are the Columbia Suicide Severity Rating Scale, which is a triage version. We have a PHQ-9 adolescent version, and we have patient safety screener. Examples, the screening for the ASQ right here to the right. It's asking Ask Suicide Screening, recommended by the National Institute of Health. We have the Columbia Suicide Severity Rating Scale listed here, and this is an assessment tool that evaluates suicidal ideation and behavior. And again, the questions go down here, and there can be notes taken at the bottom, and this is going to be checking for risks and protective factors that are present for the client. Continued here, we have the CSSRS suicide continued, and at the bottom here we would be adding up the sum of the scores to get an idea of how severe or how at risk the client is based on this screening tool. Again, it's continued. It's again, the psychometric properties have been evidenced to be excellent with internal consistency, the total score factors and the most severe ideation single items were moderately correlated with other measures of suicidality. And here, based on this slide, we have self-injurious behavior, NSSI, in the DSM-5 is how it's noted. And the DSM-5 criteria for non-suicidal self-injury disorder includes these criteria on here, which would be all-inclusive for this diagnosis. Individually having deliberately inflicted self-harm on 5 or more days within the past year. It goes on to have a few more details within this, leading up to the behavior does not only occur in the context of delirium, psychosis, or substance use withdrawal. It's not socially sanctioned or limited to minor self-injuries, and the individual is experiencing interpersonal problems, negative thoughts or emotions, and are preoccupied with self-injurious thoughts before the behavior. We have a scale here, the non-suicidal self-injury assessment tool, the NSSIAT, which shows mild to severe based on 0 to 4, and this is adapted from the NSSIAT. So if we see here, this non-suicidal self-injury risk assessment scale would ask the clients questions based on a Likert scale from, strongly disagree all the way up to strongly agree. So the higher the score, the more likely they are to be at risk. We have a major and mild neurocognitive disorder in the DSM-5, which is listed as specifically Alzheimer's disease, G31.84. Mild neurocognitive disorder due to Alzheimer's disease without behavioral disturbance, and this is dependent on, basically dependent upon high school education is the 2 variations of what the scale would pertain to. So if they didn't have a high school education, the normal would be 27 up into a 30 if they were high school educated. So the same thing from, all the way from normal to dementia, from a 1 to a 19, dependent on high school education, would be indicative of a diagnosis of dementia. And here we have a SLUMS examination, which is a neurocognitive evaluation tool that is used to determine the level of neurocognitive dysfunction in a client. We also have interpersonal violence, domestic violence abuse, listed under the DSM-5 as T74.11XA. There are some specific screening tools used for this diagnosis, specifically the adult maltreatment and neglect problem is the definition, and the instruments used are known as the HITS, the HITS. It is a short domestic violence screening tool for outpatient settings. There's also the WAST, the WAST, and that is the Women Abuse Screening Tool. And there's also other screening tools available for verbal, emotional, physical, and sexual abuse. So if the score is over 17 on this, based on this screening tool, the HITS, they would not be considered to be an abusive situation. Under 15 would be considered that they are at risk and are in an abusive situation. And this slide is my references, and I hope you enjoyed. Thank you.